My name is Tesfaye Kalila. I'm one of the interventional cardiologists at the Piedmont Heart Institute working out of Fayetteville and Noonan, Georgia. Today, I will be talking about mechanical circulatory support devices in decompensated heart failure with emphasis on patient selection and timing. I have no relevant financial disclosures. If you look at the epidemiology of shock, cardiogenic shock is interestingly the most common type of shock in contemporary critical care unit. And of those, heart failure shock is in fact the most common subtype of cardiogenic shock, followed by acute MI shock. But despite the rigorous advances and work that has been done in this space, the mortality for cardiogenic shock patients remains staggeringly high. And it's not for the lack of trying that these patients continue to die. As you can see here, most of the things that we try to do to salvage these patients is actually based on very limited randomized clinical trial data or no data at all. And if you also look at the randomized clinical trials that are performed in the shock space, most of them, in fact, were performed with an emphasis on acute MI shock, and there's very limited to no data, RCT data, specific to heart failure patients. However, if you look at these two disease entities of the same umbrella term of cardiogenic shock, acute MI shock is in fact an acute coronary catastrophe that quickly deteriorates into ventricular calamity with cardiovascular collapse and spiraling ischemia that is orchestrated by vascular response, mostly vasoconstriction, and also concomitant systemic inflammatory response syndrome, which will culminate in death if not interrupted at some point. However, if you look at heart failure shock patients, these are chronically sick NYHA class 3 to 4 patients that have been walking around with ejection fraction of 15-20% and cardiac output of less than 2, cardiac index of less than 2. And at some point they end up in the hospital because they get AFib or decompensated due to the progression of the disease with LV maladaptive remodeling and also beta-adrenergic receptor downregulation. And some people actually refer to this group of patients as chronic anaerobes because of the low flow state that they have been experiencing for a long time. So to treat these two patients as the same would be probably a mistake. In terms of their clinical presentation also, AMI shock patients usually present with typical hypotension, hypoperfusion, and congestion. Most of heart failure patients actually present with congestion first, congestion, hypoperfusion, and hypotension. So if you're waiting and stuck on the rudimentary blood pressure definition of shock, we may in fact miss some of the heart failure shock patients. And by the time we activate their management, it may be too late and maybe the horse is out of the barn. Over the last couple of days, couple of months and years, a lot of progress has been done in terms of defining shock because not all shocks are created equal. So a lot of defining work has been performed, and in that regard, the Sky Shock staging system by Dr. Hari Naidu and his colleagues for Sky consensus document has been very instrumental in terms of classifying these patients based on their hemodynamic profile, hemometabolic profile, and also clinical profile data. And to add a granularity to this classification, the work that has been done by Dr. Kapoor's team in terms of coming up with 3 distinct shock phenotypes, namely non-congested, cardiorenal, and cardiometabolic types of phenotypes, is very exciting, and it may be opening a huge door in terms of stratifying and catering specific therapy for this specific group of patients. If you look here, and I'm trying to put the SkyShock staging system side by side with these three distinct phenotypes. Phenotype 1 being a ventricular problem, phenotype 2 being a forward flow problem with cardiorenal type, and phenotype 3 is actually a congestive hepatopathy and nephrosarca, maybe with some lactic acidosis. And it seems like whichever Sky stage you get admitted with, be it C, D, or E, if you get admitted to the hospital with a phenotype 1 shock, your mortality is way lower compared to patients who are admitted to the hospital with a phenotype 3. So which is really a very, very helpful information to have when you deal with patients and when they hit your emergency room. Of course, we don't expect a class 1A recommendation in the shock space from any cardiology society. AHA suggests the use of temporary mechanical circulatory support device over durable MCS when immediate stabilization of the patient is needed, or if the patient is too sick to undergo a durable VAD or transplant surgery, or if support is required to facilitate definitive intervention like high-risk PCI or high-risk VT ablation. Also, when time is required to make a decision, like this one, some of these patients come to the emergency room, you've never met them, don't know them, they don't know you, they're too sick, but you don't know if they're going to have a meaningful exit strategy, in which case you would go ahead and put a device, and I will give you some time to make a decision about their care. Which brings me to the idea of exit strategy. Before you put any mechanical circulatory support device for patients with advanced heart failure, it's always important to explore your exit strategy. Where are we going with this? Are we expecting recovery? Are we expecting to bridge to transplant? Or are we expecting to bridge to VAD, which could be a bridge to bridge? Or is this a bridge to decision that we just don't know this patient enough and we put a device and involve palliative care and etc. The spectrum of acute MCS devices in today's cardiogenic shock space is growing. Of course, the balloon pump is one of the earliest mechanical circulatory support devices, which I will talk about in a little bit. But of course, for the sake of time, we won't be able to go through all these devices, review all these devices, but I will talk about a few of them in brief. Impella is a transvalvular rotary pump, which is an axial flow continuous pump, which sits across the aortic valve and pumps blood from the left ventricle to the aortic root. The initial, this device has undergone several iterations, and the initial one being Impella 2.5, followed by Impella CP, Impella 5.0, and now currently we have Impella 5.5 with Smart Assist. Like any other rotary flow, the device flow is directly proportional to the speed you dial in and inversely proportional to the LVAO gradient, which means that the thicker your ventricle, the more robust flow you're going to get from this device. Of course, access site has always been the Achilles heel of vascular complication, has always been the Achilles heel of this device. And to tackle that, the Impella ECP, which is probably going to be a 12 French sheath, is currently under development. The PHP device is still investigational. The idea with the PHP device is to have a 14 French insertion profile to 24 French transvalvular profile. However, this device has recently, the trial that is recruiting for this device that is comparing high-risk PCI for a PHP and any type of Impella has been discontinued due to device-related issues. SHIELD-Q trial. The tandem heart is an LAFA circuit, which is a very robust rotary centrifugal flow. However, probably due to technical difficulties with transseptal access, this device is not being used as much. But of course, it's a very, very good device. If you have LV thrombus, for some reason you can't use Impella, you can use tandem heart. The VA ECMO is in a way it's a truest form of circulatory support, but obviously it's a large bore access, and also there is some concern about the increasing afterload and ventricular dilation, increasing filling pressures on the LV, and maybe causing pulmonary edema if this device is used in patients who are having very low EF and also high filling pressures. And of course, this has not been confirmed in every patient that undergoes ECMO placement. There are at least two theories: the Burkhoff model and the Dickstein model. So there is more to be learned about this device, but this is one of those devices that is quickly moving from the OR into the cath lab, and we have a lot of learning to do about BA ECMO. So if you look at MCS use in general, this is a report from Cardiogenic Shock Working Group by Dr. Kapoor's team. It's a very heterogeneous. It's a very different, institutions use different devices, and there's really no clear explanation as to why there is this much of heterogeneity, except the fact that we don't really have any randomized clinical trial data to suggest the utility of one device over another for a specific group of shock patients. But regardless, suffice to say that intra-aortic balloon pump is probably the most commonly used device overall. But as you can see, the sicker you get in the shock stage, like for stage D, E, you see more combination of devices with like Impella and balloon pump, Impella, balloon pump, and ECMO, or ECMO and Impella, like the ECPella setup. I would like to take a minute to talk about intra-aortic balloon pump as this pertains to heart failure patients, because this device is the most commonly used device, and it seems to have a niche for advanced heart failure patients who are in acute decompensated heart failure, particularly those who have very high systemic vascular resistance. It is a very simple device, and it is placed mostly through the femoral artery, or can also be placed through the axillary artery. And it deflates in systole by creating a negative pressure in the aorta. And that negative sink, using the Windkessel phenomenon, it seems to reduce systemic vascular resistance and unload the ventricle. Of course, the unloading that you get from intra-aortic balloon pump is not as robust. It cannot be as robust as the transvalvular or any of the rotary pumps, but it does increase the cardiac output by about 0.5 liters per minute to maybe 1 liter per minute. It also inflates during diastole, and it increases the aortic diastolic pressure, mean diastolic pressure, which increases coronary perfusion, and which is we all know about the augmented diastolic pressure, which is higher than the unassisted systolic pressure, can be easily pointed out on balloon pump tracings. But what seems to be missed sometimes is this diastolic and systolic unloading of the balloon pump. So it's very important to actually assess the systolic unloading with a assisted blood pressure that is lower than unassisted systolic pressure. And also, of course, invasive hemodynamic monitoring with mixed venous oxygen saturation and also right atrial pressure will be very, very important. So in a nutshell, MCS for decompensated heart failure, which patients would benefit from MCS? And all patients with high-risk features that include escalating doses inotropes, multiple heart failure hospitalizations, and declining hemodynamics and hemometabolic profiles, with cardiac power output with PAPI less than 1, cardiac power output less than 0.6, mixed venous oxygen saturation, and also delayed lactate clearance would be those patients on whom will have very low threshold to actually place an MCS. And also timing of MCS is very crucial. If you look at this slide here, of course, this was for durable VAD, 1 year heart failure mortality plotted against a 1 year MCS mortality is stratified by the intermax profile of the patient. In the timing where you put the durable VAD seems to really be one of the most important things that you need to pay attention to, because if you put any device too early in the course of the disease, it's going to be unnecessary burden to the patient. And also, if you put it too late, it will be futile. The patient would not really benefit from it. So that window of intermax 2 to 3 is probably when we need to consider to put the ventricular support devices. However, these patients, because of the understandably stringent criteria for durable VADs, they may not get the VAD at this point, and they may quickly deteriorate into the crash and burn intermax 1. At which point, we have to place, if there is an exit strategy, we have to place a temporary MCS to actually recover them and make them better to actually undergo the VAD surgery. So timing is very, very crucial. The kind of the same thing here. If you look at the NYHA classification against the intermax disease profile, around intermax 4, it would be the time that we need to start thinking about some durable interventions, and that is recurrent decompensation, increasing inotropic requirements, progressive decline in their function, and also presence of and worsening cardiogenic shock, which would be SCAI stage E. At that point, we need to really act and place an MCS. Even when the patient's blood pressure is, quote, stable on 3 pressors, it's really not very reassuring. We already know about the use of inotropes. If you have escalating doses of inotropes and more inotrope types, your mortality skyrockets very quickly. And if you have on 3 high dose pressors, that patient's mortality is about 80%. And of course, after we place any mechanical circulatory support device, we have to assess response. And the response could be hemodynamic response, which hemodynamic monitoring, hemometabolic monitoring, and also device function monitoring. And if you place any mechanical circulatory support device, please make sure you place an invasive hemodynamic monitoring Swan-Ganz catheter and do your CPOs, PAPIs, mixed venous oxygen saturation, cardiac index, and cardiac output serially to see the response to the device. If the patient is not responding to the major device intervention, you have to think and escalate to a better device, a bigger device, and also optimize your medical therapy. Lactate clearance and creatinine also LFTs would be a very nice way to keep an eye on hemometabolic profile. Also, like I said, after you put a device, you have to monitor for device complications. Also look at your balloon pump tracing. If you put a balloon pump, not just the systolic, not just the diastolic augmentation, but the systolic unloading, which seems to be actually more important for this group of shock patients. So in conclusion, heart failure shock and AMI shock, they have 2 relatively distinct pathophysiologic bases. And whenever you put a device in a heart failure patient, make sure you have some kind of exit strategy. If you don't, you're probably doing the device for bridge to decision. And invasive hemodynamic monitoring is crucial to assess MCS response. And appropriate risk stratification requires a multidisciplinary approach. which includes heart failure specialists, interventional or critical care ICU cardiologists, cardiac surgeons, case managers, social workers should be part of the team. And the better the shock team we have, the better probably the outcome is going to be. So in a nutshell, the key is to identify patients before incipient indoor gun failure ensues. And thank you for your attention.